Dear delegates, please welcome Dr. Shriganesh Patil for the next talk on refractory status epilepticus.
Good morning all. As I have to cover the vast topic in the next 20 minutes, so without wasting time, I will start my talk, that is management of refractory status epilepticus. This will be the outline of my presentation. We will see the new ILE definition of the status epilepticus. They have new two terminology, that is time point T1 and time point T2. We will see the management mantras in the form of how hit early and hit hard is useful in the management of the status epilepticus. We will discuss about the out of hospital, home management and primary health care care management of the status epilepticus, and we will see management of refractory status epilepticus and super refractory status epilepticus in the PIOC setting. This is how the definition of status epilepticus has evolved over the time. In 1981, it was taken as in 60 minutes, whereas it was cut down to the 30 minutes in 1993 by the ILE, that is International League Against the Epilepsy. As the time advances, it was further cut down, and now we will take as any seizure that is lasting for more than 5 minutes or any patient who is coming to your OPD or hospital in convulsive status, we will label it as an status epilepticus. But this is operational or practical definition of status epilepticus. Recently, International League Against the Epilepsy, that is ILE, given the conceptual definition of the status epilepticus, and they have given the two time points, that is time point T1 and time point T2. So what do you mean by time point T1? So it is the time at which natural mechanism of brain will fail, and then the seizures will not stop by themselves, and we have to start the treatment, otherwise the patient will go into the status. And what do you mean by time point T2? It is the time till that we have to stop all the seizures, or we have to stop the seizures, otherwise there will be the long-term unnecessary complications because of the neuronal death and neuronal injury. So in short, time point T1 means treatment should be started as we have to start the treatment, whereas time point T2 that we should control all the status epilepticus. These time point T1 and T2 are different for the different type of status epilepticus. In generalized status epilepticus, we will take as T1 as a 5 minute and T2 as a 30 minutes. In focal seizures with impaired awareness, we will take T1 as 10 minutes and T2 as a 60 minute, whereas rarely we can get the absent status epilepticus. And there is one neurological condition called Angelman syndrome, where we will get the absent status epilepticus, where time point T1 is defined at the 10 to 15 minutes, but time point T2 is till not defined. So there are different stages of status epilepticus. Stage 1, that it is initially 5 to 10 minutes, we will call it as an impending status epilepticus, where we will use the benzodiazepines. Stage 2, established status epilepticus, when benzodiazepine fails, we have to use the second line anti-seizure medicines. Stage 3, refractory status epilepticus, that is status epilepticus that continues despite the stage 1 and stage 2 treatment, whereas the stage 4, super refractory status epilepticus, when status epilepticus continues even after the 24 hours use of IV anesthetic infusion. So goals of management of status epilepticus are, yes, obviously the first and most important goal is to control the seizures, otherwise the patient will go beyond the time point T2 and they will have the abnormal morbidity, or they will have some morbidity with them. And apart from the controlling the seizures, another most important goal is to prevent and treat the systemic complications associated with the anti-seizure medicines, systemic complications associated with the IV anesthetic medicines, and systemic complication associated with the prolonged PI system. So management mantras are hit early and hit hard, like our own rising star, Arshin Kulkarni. So what do you mean by hit early? So studies have found that the group which has received the third anti-seizure medicine within the 16 or within the 1 hour of first anti-seizure medicine, the seizure control will be the 100%, versus the another group where there is a delay in the administration of third anti-seizure medicine from the first anti-seizure medicine. The group who have received third anti-seizure medicine within the first hour of first anti-seizure medicine, almost 80% cases has returned to the baseline, whereas 0% in the another group. So the message is, anti-seizure medicines are more effective when they are administered earlier in the course rather than late in the status epilepticus. Another study, what they have studied? They have studied the time of administration of benzodiazepine from the onset of the seizures, and they have evaluated results in the form of mortality and the requiring of IV anesthetic medicines. So dark purple group is the benzodiazepine received within the 10 minutes of the onset of the seizures, and there is no mortality in that group. The date is 0 in that group, whereas they have less requirement of IV anesthetic medicines. So timely administration of benzodiazepine is very critical. Administer the benzodiazepine within the 10 minutes of the onset of the seizures, otherwise mortality will be high and they will require the frequent IV anesthetic infusion. They are associated with their own complications. After hit early, what do you mean by hit hard? It was found in routine practice that most of the pediatricians are giving the anti-seizure medicines at suboptimal doses. What they label it is an half loading dose. So there is no concept of half loading dose. Load the anti-seizure medicine at the appropriate doses. For most of the anti-seizure medicines, they are 20 to 30 milligram per kg. Give the infusion at the maximal possible rate under the monitoring. Be ready with next anti-seizure medicine in line before the present infusion is completed. So it was found that pre-hospital management, either in the home or in the primary health care center, is play critical role in the management of status epilepticus. The pre-hospital management will reduce the duration of status epilepticus, as well as it will reduce the recurrent seizures in the emergency department. It also have impact on the intubation required, ICU admission, and the hospital stay. So how we can give the pre-hospital management at home in primary health care center where IV access is not possible? So there are different non-venous medications, and this meta-analysis told that efficacy of various non-venous medication in acute convulsive seizures. And from the table, it is clear that first line and second line all are benzodiazepine. Whatever may be the route, it may be intranasal, it may be intramuscular, it may be buccal, or it may be per rectal diazepam. So which benzodiazepine is used in the pre-hospital management of the status epilepticus? In primary health care center, we can use the intramuscular midazolam where IV access is not possible. At home, now in market, midazolams are easily available, so we can use the intranasal midazolam. Intranasal lorazepam is also efficacious, but the preparations are not available in the India. We can use the buccal midazolam and we can use the rectal diazepam, but they have some social issues. Regarding the hospital management of the impending seizure or status epilepticus, the Cochrane systemic reviews in 2018 has compared the IV lorazepam versus IV diazepam in terms of the seizure control, in terms of the side effects like respiratory depression, and in terms of the incidence of ICU admissions. And what they found that both are equally effective. IV lorazepam and IV diazepam are equally effective, but the trends or most of the pediatricians are favoring the lorazepam because of the less side effects, that is respiratory depression. After failure of the first benzodiazepine, now we are dealing with the established status epilepticus. And now what options we have? We have second line anti-seizure medicines like phenytoin, phenobarbital, sodium valproate, and levetiracetam. Regarding the efficacy of second-line anti-seizure medicines in the management of the status epilepticus, all are found to be efficacious between the 50 to 75%. So there is not a big difference. All are equally effective, none is superior than the others. So you can use any anti-seizure medicine, second-line anti-seizure medicine that is available in your PICU setting. What if the seizures are still persisting? That is, even after giving the benzodiazepine, even after giving the 2 appropriate anti-seizure medicines at appropriate doses, seizures are still persisting. It means now we are dealing with the refractory status epilepticus, and it is defined as persistence of the electrographic or clinical seizure activity even after giving the 2 appropriate anti-seizure medicines at the appropriate doses. And what options we have? We have third-line anti-seizure medicines in the form of IV anesthetic infusion. Commonly used IV anesthetic infusers are midazolam infusion, thiopenton, high dose of phenobarbital, propofol infusion, and in recent advances, ketamine infusion, and inhalational anesthetics like isoflurane. So What are the commonly using first line IV anesthetic infusions? So commonly we are using midazolam in our routine practice, propofol we are also using, then we are using the thiopentol. I am not going to the deeper of the doses because as time is only 10 minutes remaining. So these are commonly used IV anesthetic infusions we are using in our day-to-day practice. Regarding the efficacy of commonly used IV anesthetic medicines in our day-to-day practice, most of the intensivists or most of the pediatricians are using the midazolam infusion because it will have the good seizure control. But the disadvantage will be the risk of breakthrough seizures. Thiopentone, yes, possibly more potent, but associated with the more side effects and higher mortality. Propofol, we can use the propofol, it is suited for the short term use only. We cannot use the propofol beyond the 48 hours because there is a risk of propofol infusion syndrome, which is a multi-organ failure condition. What level of anesthesia is desired in case of when we started the IV anesthetic infusion? So continue anesthesia till you will get the burst suppression pattern. So here comes the role of EEG in case of the status epilepticus. So yes, EEG is useful to see the burst suppression pattern as well as it will identify the children with the non-convulsive status epilepticus. After coma conduction, if you got the burst suppression pattern, you got the good clinical seizure control, then continue that level of coma induction or that level of IV anesthetic infusion for minimum 24 hours and then next try to taper over next 24 to 48 hours. Suppose after the particular coma induction you got the seizure control and you have started the tapering the midazolam drip, but again seizure has recurrences. So now it means we are dealing with the super refractory status epilepticus, and it was defined as continuous epileptiform activity after the starting of 24 hours after the starting of the IV anesthetic medicines or recurrent epileptiform activity after the anesthesia weaning. And what options we have available? We have to re-establish the IV anesthetic infusion at the same level where we have obtained the burst suppression pattern or good seizure control, and it is called as an cycling of anesthetics. And there are many cycles may be required, maybe 5, maybe 7 cycles may be required, and there are no clear-cut guidelines how many cycling of anesthetics we can do. Regarding the recent advantages in the management of the super-refractory status epilepticus, the article on intravenous ketamine in the status epilepticus. So intravenous ketamine was found to be efficacy in 73% of the cases. And the interesting thing is, when you co-administered with the midazolam infusion, it will have the synergistic effect. There are side effects are very non-specific in the form of irritability, hallucination, increased salivation, and dissociative psychosis. Is early administration of ketamine is effective? The study has shown that when you administer the ketamine at low infusion rate, when you administer the ketamine 8 days after the onset of the status epilepticus, or when you administer the ketamine after the failure of 7 anti-seizure medicines, the efficacy of ketamine will be the low. So start the ketamine in the early course of the status epilepticus. So ketamine is safe in children, possibly effective, should be started in the early course and co-administered with the midazolam infusion. That will have the synergistic effect. Regarding the isoflurane, it is the good thing is it will have the very rapid of onset within the minute, but the disadvantage is on tapering the isoflurane, the chances of recurrence of the seizure is high. So it is the good drug for the immediate control. Regarding the newer anti-seizure medicines in the management of refractory and super refractory status epilepticus, what happened on day 3 and day 4 onwards of status epilepticus, there will be the internalization of the GABA receptors. So now GABA receptors are not available. So it is not a good idea to give the drugs that are acting on the GABA receptors, and there is overexpression of the AMPA receptors as well as the NMDA receptors. So give the drugs that are targeting on the AMPA receptors and NMDA receptors, like perampanel, which has novel mechanism of action. It is the first oral AMPA receptor antagonist. In my personal experience, I have used the perampanel loading dose of 18 milligram in 2 patients, and that will have the good seizure control in the status epilepticus. Lacosamide in the status epilepticus, overall efficacy is the 57%, and it is a wonderful drug in the focal status epilepticus. It will have the efficacy of the 92% in case of the focal status epilepticus. Regarding the ketogenic diet in super refractory status epilepticus, it is useful because it has mechanism of action that is different from the anti-seizure medicines, and it is particularly useful in a FIRE subgroup, that is febrile infection related epilepsy syndrome. It is a subgroup of super refractory status epilepticus. So ketogenic diet has a role in the FIRE subgroup, FIRE, that is febrile infection related epilepsy syndrome. Regarding the FIREs, we can use the intrathecal dexamethasone 0.2 milligram per kg on alternate days for 5 days. We can use the cannabidiol. Now cannabidiol is also easily available in the India, but it is costly, but now it is available in the India. Regarding the immunotherapies have the role in inflammatory and autoimmune disorders. First line immunotherapy will be the pulse methylprednisolone 30 milligram per kg for 5 days. IVIG are the first line immunotherapy. We can use the second line immunotherapy like rituximab, cyclophosphamide, tocilizumab. So regarding the complications of status epilepticus, it was found that mortality rates are not because of the status epilepticus per se, but higher mortality say in case of when you treated the patient with the IV anesthetic patients. So it is time to define the threshold at what level of we have to go to the IV anesthetics, otherwise that will land up in the fatal systemic complications of the IV anesthetic medication. So regarding the same, a case report, a case published recently, avoiding the anesthetics after the multiple failed drug induced comas. This is an unorthodox approach in the management of NORS, that is new onset refractory status epilepticus. What they have 19-year-old male which is requiring the 7 failed drug induced comas until 28 days of the hospitalization. So finally intensivist has decided that they will now they will stop all the IV anesthetic medicines, and they will treat only generalized tonic-clonic seizures or electrographic status epilepticus. And by doing that, they have avoided the fatal systemic complications of the IV anesthetic medicines, and they have successfully recovered their patient. So it is the time all the superheroes from the pediatric critical medicine should sit back and think about the threshold or at what maximum level of IV anesthetic medicines we can use in the case of refractory or super refractory status epilepticus. There are some recent articles also in the role of enteral rolazepam in the patients we have difficult to wean from the midazolam drug. So they have calculated some specific dose of enteral lorazepam depending on at what level of midazolam infusion is going on, and that is found to be the useful while weaning off the patients from the which are difficult to wean off from the status epilepticus. Regarding I will wind up with the last 2 minutes with the proposed protocol in the management of the status epilepticus in the children. In impending status epilepticus, IV lorazepam is preferred. Dose is 0.1 milligram per kg, maximum 4 milligram. We can use the midazolam 0.15 to 0.2 milligram per kg, maximum is 5 milligram. You can use the 2 times. If the seizures are still persist, then we can use the phenytoin 20 milligram per kg. Still seizures are persist, we can use the 1 more 10 milligram per kg. Seizures persist, we can use the valproate, levetiracetam, phenobarbital. If PICU facility is available, ship the patient to the PICU, give IV phenobarbital, or start the IV anesthetic infusion. If PICU facility is not available, you can use the second line anti-seizure medicines depending upon what two are previously used, or you can try the topiramide or lacosamide if PICU facility is not available, or if you don't want to ship the patient to PICU, or you don't want to start the patient on IV infusion. If seizures are still persist, even on the midazolam infusion, we can have the options like high dose phenobarbital, bolus of 10 milligram per kg over 15 minutes, followed by phenobarbital infusion at the rate of 1 milligram per kg per hour, increase at the rate of 0.5 milligram per kg per hour to maximum of 3 milligram per kg per hour. IV thiopentone, loading dose of 5 milligram per kg followed by the bolus of 3 to 5 milligram per kg per hour. Short-term propofol, as already told, should not be used more than 48 hours because the risk of propofol infusion syndrome. The loading dose of propofol is 1 to 2 milligram per kg, followed by the continuous infusion of 1 to 2 milligram per kg per hour. Recent advance is ketamine, loading dose in the form of 1 to 1.5 milligram per kg, followed by the maintenance of 10 to 50 microgram per kg per hour. If the still seizures are persist, so there are desperate measures for the desperate situation. People are trying the thalamic deep brain stimulation, they are trying the vagal nerve stimulation, but these are not recommended or these are not commonly used in the practical. Magnesium infusion can be tried in the fires. Immunotherapy can be used, epilepsy surgery, ketogenic diet in the febrile infection related epilepsy syndrome. We can try the topiramate and lacosamide also. Sometimes by doing all the things according to the protocol, still we are unfortunate to get the situation under the control. And in that case, this will be the good option to get the situation under control. And thank you. I hope I have respected the time.